Hi everyone, I'm Dr. Jyothipriya. I'm consultant nephrologist working in Muthoot Medical Center, Pathanamthitta in Kerala. I'm here on behalf of the social media team of Women in Nephrology Conference, Win Icon 2023, which is the second annual conference of Women in Nephrology India, Win India, that will be held on August 5th and 6th this year in Bangalore. Today, we are having a session of pre-conference interview, and we have with us none other than Dr. Anna Valsan, Specialty Doctor, Renal Medicine, NHS Grampian, UK. She has over 13 years of vast experience in nephrology, and she is very much passionate about research activities. Her field of research interests include living kidney donor outcome, low-cost alternative to dialysis, and complications of chronic kidney disease, especially bone mineral disease. She has served as the Honorary Research Fellow in University of Aberdeen, UK. She moved to UK after 15 years of exemplary service in Christian Medical College, Vellore. She has several publications in national and international journals, and currently she is the principal investigator of multiple research projects. We are indeed very much fortunate to have you with us, Dr. Anna, and also for our Winicon conference, for being part of us. We are really fortunate, and it's an absolute pleasure to be with you, ma'am. Over to you, ma'am.
Thank you, Jyothipriya. I'm really grateful to the organizers for inviting me to give a talk at this conference, and I really appreciate the role of a forum such as WIN, especially as in my own experience, I find that women scientists, women doctors have very little opportunity to network, to meet with fellow women scientists or doctors and learn from their experiences and use those insights to help them develop a career and plan how they should go about building their career. So I think a forum like this is really useful, and I'm so glad to be part of it. Thank you.
Thank you, ma'am. Moving on to our topic. We know globally the prevalence of CKD has almost doubled over the last 2 decades, and growing number of CKD cases had led to potential increase in the burden of bone and mineral metabolism disorders. And our CKD patients have a higher incidence of fracture, especially hip fracture, compared to patients without CKD. Furthermore, according to the results of dialysis outcome and practice pattern study, patients undergoing hemodialysis have higher rates of fracture, death, and hospitalization than non-CKD dialysis population. And osteoporosis is a real concern in CKD patients, and diagnosis of osteoporosis and prevention of related fragility fracture is complex in CKD, especially in advanced CKD and end-stage renal disease. And there are no standardized treatment recommendations for how to treat osteoporosis among patients with advanced CKD. So in this background, I would like to put forward a question to you, Dr. Anna. We have several treatment options for osteoporosis in general population, like bisphosphonates, teriparatide, denosumab, raloxifene. So, in your opinion, is denosumab one of the best choice for treatment of osteoporosis in CKD patients? Let me rephrase. Is it superior in preventing fractures and also in increasing the bone mineral density in CKD patients?
Right. So that's a very complex question, and that's because denosumab should be used in a very specific group of patients, especially when you're using it in CKD patients, simply because osteoporosis will, in these patients, coexist with CKD-MBD. And CKD-MBD itself is not one entity. There are many pathologies, and they all behave differently. So denosumab is best used in CKD patients who do not have a low turnover bone disease. And that's the crux of the matter. The problem is that it's often difficult to even diagnose low turnover bone disease because our markers are not very good. And DEXA scan will not help you in any way in deciding whether you have a low or a high turnover bone disease. Or all it will tell you is that your BMD is low. And a low BMD can be found in any type of renal osteodystrophy, whether it's um, secondary hyperparathyroidism, whether it's adynamic bone disease, whether it's osteomalacia, they all, and osteoporosis, all of them will have a low BMD. So really, you don't know what you're dealing with.
Oh.
So the only thing you can use to help you make sure that you're not using denosumab in a patient with low turnover bone disease is to probably monitor PTH. Um, there's also bone specific alkaline phosphatase, but we don't have it in most centers. So you're basically left with PTH. And in PTH itself, there's so much variability. Even the KDIGO talks about a range between 2 and 9. So you can be relatively safe in using denosumab when the PTH is above 9 times the upper limit of normal. But there's a huge gray area between 2 and 9 where you don't know what you should be doing really, which is where there's a role for a bone biopsy. Again, centers can't do a bone biopsy. I don't know of any center in India that has the facility to do a bone biopsy. It's even rare abroad. And below, when your PTH is less than 2 times normal, denosumab should definitely not be used. Those are the group of patients in whom you would use an anabolic agent like teriparatide or romosumab. So um, really, it's a very select group of patients in whom you can be fairly certain you're not dealing with a low turnover bone disease, and people who have either an existing fracture, vertebral or non-vertebral, or at a high risk for fractures, assessed by a DEXA scan which shows a low BMD
Okay.
or maybe a FRAX score. Yeah.
Okay. Thank you. And my next question is on the safety of denosumab and its side effect profile in CKD patients. Dr. Anna, you have a publication on CKD-MBD, mineral bone disease, and in your research, it showed that CKD-MBD in Indian CKD patients, it's unique that in them the hypocalcemia and vitamin D deficiency are more common compared to the Caucasian cohorts. So in the light of this study, is denosumab a safer option or safer choice of agent in Indian CKD patients and also in dialysis patients? Especially, we have studies showing that hemodialysis patients on denosumab, they have a higher rate of hypocalcemia compared to non-dialysis or compared to general population. So what is your opinion regarding its safety profile?
Yeah, unfortunately, we don't have data from India, and that's crucial. I find that a big problem for Indian nephrologists is we have to use Western data and then decide what's best for our patients. And the same treatments may not work as well, and you may have a different side effect profile. You're absolutely right. We do have, and my publication was on pre-dialysis patients. So these were patients who were between CKD stage, were between 3 and 5 CKD, had never been on dialysis, but also had never been on vitamin D and calcium supplements for, I mean, they hadn't had it for more than 2 weeks. So it's a different group of patients we're talking about. In that group of patients who were treatment naive, so to say, yes, there was a high prevalence of hypocalcemia. But I would say that in my experience, even using cinacalcet in Indian patients, far more hypocalcemia than we see in the West. And that's simply because our diet is different. The overall calcium content in an Indian diet is usually is less than 500 milligrams per day. So we usually have a diet which is low in calcium, except in certain states where there's a huge consumption of dairy products, say Punjab, Haryana. There's a belt where they have a higher daily calcium intake. But for most of India, that's not the case. So you have low calcium intake. You have low vitamin D levels because our skin requires greater sunlight exposure, especially the more dark skinned you are to synthesize the same amount of vitamin D. And nowadays, people are not spending as much time outdoors. So there's also a lot of, there's malabsorption. Um, Generally, nutrition is poor. So there are all these risk factors for hypocalcemia already in the population. So one would expect that in our patients, just as I have anecdotally seen with cinacalcet, we can expect that we'll have the same problems with denosumab. Now, even in the Western population, they have seen that in the CKD population, on an average between, it can be around 14-15% hypocalcemia. If you use it in the hemodialysis population, that can go up to 35%. And this is particularly so if you have not preloaded a patient with calcium and vitamin D and ensured that they continue on those supplements. So hypocalcemia is definitely worse if you have not optimized their CKD MBD management before starting denosumab. So that's another key practice point. One must put the patient on calcium and activated vitamin D supplements. And ideally, these activated vitamin D supplements have to be taken daily, not alternate day or twice or thrice a week. So daily activated vitamin D, at least 1,000 milligrams of calcium every day before you start denosumab therapy, and make sure serum calcium is normal
Okay.
and serum adjusted calcium is normal,
Okay.
and continue to monitor. So that you should monitor at least weekly for the first 12 weeks, because the risk of hypocalcemia is greatest in the first 12 weeks. So you need to, so the patient also has to be around for close monitoring. So it's not simple. And often if you have severe hypocalcemia, especially in dialysis patients, you may have to resort to IV calcium. You may have to raise their dialysate calcium. So it can be quite difficult. And because the effect of denosumab lasts for a long period, I've had colleagues who've said it's taken 2-3 months for the calcium to sometimes normalize. Yeah, yeah. And the other thing to understand is, because the serum calcium levels are maintained by osteoclasts acting on the bone, when you damp down osteoclast activity, that's why calcium falls. And simply by giving calcium, it takes time, because osteoclast activity remains dampened. So that's why it takes time for calcium levels to normalize. Yeah.
And what's your opinion on the safety of denosumab in hemodialysis patient? Because our evidence regarding its usage in hemodialysis patient is very much limited. So, in your experience, what's your opinion on it?
Yeah, unfortunately I don't have experience, but like I said, I've talked to my colleagues here who've used it in hemodialysis patients. So definitely, like I said, the incidence of hypocalcemia is higher. It takes longer to correct the hypocalcemia. um, in terms of actual efficacy, they haven't found any difference in the effect that denosumab has on BMD or fracture prevention between CKD um, and non-CKD patients or hemodialysis patients. So its efficacy appears to be uniform across EGFR groups, but the side effect profile is definitely worse in hemodialysis patients. Hypocalcemia is the main thing that you struggle with. So like I said, up to a third or more may have hypocalcemia, which can be difficult to treat.
And I just have a concern because studies have shown on discontinuation of denosumab treatment, there is an increased risk of vertebral fracture in immediately itself in relatively short span of time. So, considering a resource-poor setting like our country, how safe is to start patients on denosumab when we know we have to put them on an indefinite duration of treatment?
Yeah. So the problem, again, when you take off something that's inhibited, there will be a rebound increase in activity. So osteoclast activity then immediately ramps up, and that's what you see as an increased risk of fracture. Um, what is done in patients who have relatively preserved kidney function is, if you're stopping denosumab, you then have to use an alternate anti-resorptive therapy, which is basically bisphosphonates. So if you're stopping denosumab, you shift them to a bisphosphonate so that you don't see the increase in fractures. Unfortunately, if your EGFR is less than 30, there's no bisphosphonate that's approved for use at that GFR. So then you are left with lifelong denosumab therapy. So if you're initiating denosumab in someone with an EGFR less than 30, be prepared for lifelong denosumab. There is absolutely nothing else you can do. And the safety evidence that we have is only now up to 10 years based on results from the Freedom study. And even the Freedom study was not done in CKD 4 or 5 patients, and they had no hemodialysis patients. So we actually don't have it evidence based for patients with severe renal failure. Uh, the problem with this whole thing of the lifelong denosumab is it's not just the cost. Now in India, one injection is around 16,000 rupees, at least in Vellore, it is that much. It's also the cost of monitoring calcium. It's also the cost of taking the medications, which is calcium and vitamin D. There are also issues of compliance. We know our patients have a high pill burden, and it's difficult for them to comply with whatever therapy that they are given. And then to add something like calcium and vitamin D, many patients struggle to take calcium. Those are difficult tablets to take. You have to take all this into account when you decide to put someone on denosumab, and which is often what as physicians we don't think about. We don't think about how compliant our patients are going to be. We think when we give them a parenteral therapy, that's easy to do. They come in once in 6 months, get an injection and go away. But everything that they have to do in between, they have to be careful with their oral hygiene, ensure that they don't get any infections. That's difficult in India. They have to be compliant with their drugs, otherwise they'll land up with hypocalcemia, and access to medical care may not be that good. So really one has to think long and hard about type of patient you're going to start it in. There are cost implications, there are compliance implications.
Yeah, very true. Because since it's a parenteral one and 6 monthly only we have to take, so it doesn't confine to that injection. That supplements of calcium, vitamin D, all compliance should be ensured. So basically, we need to choose the right patient for starting the denosumab, right?
Correct. Yeah.
So thank you. So basically, now we will move on to our last question. So in our conference, Vinicon 2023, we'll be having several nephrology residents, young trainees, early career nephrologists. So as a senior nephrologist who have these many years of experience in this field, what is your advice or piece of message to these young budding nephrologists who will be attending this conference?
I feel really humbled to be asked that question, because I feel I'm still learning, and I probably will, till the day I die. But I think early on, one needs to be fairly clear about what one wants to do in life. Now, you can either decide that you want to go in. I'm talking about from the Indian perspective. If you want to remain, say, in private practice or in the corporate setup, I think your aim has to be to get the widest clinical experience possible. So that would involve getting trained in a high volume center. Or if you're not able to train in a high volume center, after you finish your training, go and work in a high volume center, which will expose you to every kind of case possible. Because your goal then as a nephrologist is to have a wide range of clinical experience. So in the corporate setup, you can't decide to look at only certain patients. You have to be able to manage all kinds of patients. You also have to be able to look at things behind the scene. How do hemodialysis machines work? How to run a center? All those things. So your approach to training has to take into account where you see yourself after you finish training. Okay. If you see yourself, say, in the research or an academic front, your approach is very different. Then your approach is, yes, you want clinical experience, but you also want to have a sound theoretical base, and you also want to identify an area of interest which you might want to specialize in, because that's possible in an academic setup. And there it's important to have a good mentor. So I think as women especially, this is difficult. We find it difficult. Most people in our field tend to be men. You might have difficulty approaching them, or asking them to mentor you. um, Often people don't have the time, so that, which is why a platform like this is really important, because I was really lucky that I had a mentor early in my career who has remained a guiding light for me ever since. So having a good mentor who can inspire you, they may not exactly have your area of interest, but who knows the ins and outs of the research field, how to build a research portfolio, what you need to do in order to progress, and who can correct the first couple of manuscripts, shape it, get it published, and then after that you can just take off after that. But it's often having that one person who believes in you and pushes you, that's important. And you need to also have a good set of professionals around you. I think you need to have a good team of fellow consultants whom you get along with, who you can all push each other. You have a stimulating environment around you, you will do better. And as a woman, I would say you need to have a very good support system at home, whether it's a spouse or an army of in-laws, parents. That's something people don't talk about, but as a woman you can't do all these things unless you're well supported and you feel like you can focus at work, and research, provided other things are taken care of. So I think all of these are important.
Very true, Anna, Dr. Anna. And thank you. Thank you so much for taking your valuable time to be with us in this interview, and also for being with us in the Vinicon 2023 conference. And we are actually excited and eagerly looking forward to hearing from you in the Vinicon 2023. So the discussion we had on denosumab just now is a glimpse of the great talk and discussion we are going to have in Vinicon 2023. So this discussion will be on August 6th, afternoon, 2:30 p.m. in Hall A. So viewers, please do not miss to attend Winicon 2023. It's a hybrid program. Remember the dates, August 5th and August 6th. Venue, St. John's Auditorium, Pop Poles Auditorium, St. John's Medical College, Bangalore. So do join us, and definitely it will be a great academic feast.